thank you so much. It's really nice to be part of this symposium, and probably the most favorite session I heard. So it's a real honor. Thank you. So I'm going to talk to you about pharmacokinetics of Bictegravir in pregnancy. Here are my disclosures. Oh, wrong way. I want to go back. Yes. So you've seen this slide before, but I really want to emphasize that there has been a large knowledge gap between the moment of drug approval and when PK data on those drugs has become available. And this is an updated version of the picture you saw before. And in the upper right corner, you can see a box with the drugs that has no or still limited data. So we still have work to do on this topic. Because why do we even want pharmacokinetic data when it comes to pregnancy? Well, a lot changes in a female body to accommodate, well, bringing an infant to the world. And they can also impact the drug concentrations due to changed absorption of the drug, altered metabolism, clearance or distribution. And it can go all ways depending on the characteristics of a drug. So it's really important to research this because it can impact the efficacy but also safety of the drug. So that's why years ago the PANA network has been installed, and it's European, also with one site in the Caribbean, in Curaçao lately, which has an objective to research newly antiretroviral drugs in pregnant women. So today we're going to focus on Bictegravir, which is an integrase inhibitor, and it's part of a single tablet regimen where it's co-formulated with tenofovir alafenamide and emtricitabine. And it's a highly protein-bound drug, more than 99% in vitro, and it's metabolized by CYP3A4 and UGT1A1, which I will get back to later. And here you can see the PK parameters in non-pregnant adults. So the metabolism of Bictegravir is depicted here, and you can see it goes to glucuronidation, so it's made more water soluble by UGT1A. And another pathway shown in the left corner is by oxidation first, but then sulfation by CYP3A4. So the objective of this study is to determine whether the exposure to Bictegravir is altered during pregnancy. And if so, how could this be explained? Is it by increased metabolism, or is it by an increased free fraction? And some other important things to report on is placental transfer and also efficacy and safety. We did this by taking plasma samples during a 24-hour period during the 3rd trimester of pregnancy. And then later on in the same participant, the same time concentration curve would be obtained about 4 to 6 weeks postpartum. So this way the participant could serve as her own control. So we could make a comparison in pregnant, pharmacokinetics and postpartum. And also, if feasible, cord blood was also sampled, so we could say something about infant exposure and placental transfer. So let's move on to the results. We were able to include 13 women, no preterm labor within this cohort, and most of the women were able to give a birth vaginally, and all the other ones who had a cesarean section were all due to obstetric reasons, because no of the participants had a detectable viral load at time of delivery. There were 2 participants who had a detectable viral load at inclusion, so early on in pregnancy, and there were also 2 other participants who had a detectable viral load postpartum. So here you can see the concentrations of total Bictegravir, And in orange, you can see the postpartum concentration during 24 hours. And in blue, you can see the concentrations and the corresponding 95% confidence intervals of those concentrations. And you can see the dashed line that depicts the protein-adjusted IC95, which is the in vitro concentration needed to block the viral replication. And you can see that the pregnant concentrations are considerably lower than seen postpartum, but still above that kind of safety threshold. So here are the PK parameters, and you can see the first column are the pregnancy PK parameters and then postpartum. And in the last column, you can see the ratio between the two. And you can see that the total exposure, so the area under the curve, the AUC, during 24 hours is about 53% lower during pregnancy. And also an important parameter is the C trough, which is also 62% lower during pregnancy. And you can see that the half-life is decreased. So we also had a look at the individual participants, and you can see that this trend, this phenomenon goes for all participants. So exposure is decreased during pregnancy for all participants. So how can this be explained? First, we had a look at the metabolites. So the M15, it's a product of metabolism by glucuronidation, and it's lower during pregnancy compared to postpartum, and this also holds true for the big M20, which is the product of sulfation. But if you make a comparison of the mother drug, so the total Bictegravir and the metabolite, and then make a comparison between pregnancy and postpartum, you can see this effect is even bigger. And especially for M15, which has a ratio of 266. So increased metabolism definitely plays a role here. Then what about protein binding? We know this is altered during pregnancy, and does this also affect a drug that's so highly bound as Bictegravir? And yes, it does. Here we see the unbound concentrations, which are blue in pregnancy, orange postpartum. And you can see that the unbound fraction is increased during pregnancy. So also a larger fraction is available for metabolism because the unbound drug is available. And what you see is that the unbound concentrations are therefore lower during pregnancy. Then for placental transfer, we were able to collect 3 cord blood samples and maternal blood samples during delivery. And you can see that for most or 3 samples, 2 of them, they show some accumulation in the placenta. So we sampled cord blood and maternal plasma, and if you divide those 2 together, you can get this ratio, which was higher than 1 in 2 participants. Which indicates accumulation. Then for safety outcomes, there were 3 serious adverse events reported, but we don't think they were related to the treatment. There were no vertical transmissions in our cohort, no congenital anomalies, and there were no infants with a low birth weight for their gestational age. So to conclude, we did see that exposure to total Bictegravir was decreased during pregnancy, and this also, although in lower extent, is true for the unbound concentrations for Bictegravir. And I think the most important mechanism to explain this phenomenon is the pregnancy-related induction of UGT1A. Also, the decreased protein binding during pregnancy plays an important role, and we also saw that induction of CYP3A4 plays a role as well. So we did see lower concentrations also for the unbound drug, but it still stays above the PAIC95. And there were also 2 other research groups who reported their findings on Bictegravir in pregnancy, and they also found the same. They also had the same findings, and also no vertical transmissions in their cohorts either. So placental transfer does occur, and this cohort is too small to actually say something about clinical outcomes for these children. So that's something we need to look out for. But no other safety issues were reported here. So I would like to thank certain people in my team and everyone who contributes it to the PANA network, and I'm open for questions later on.